Welcome to the Department of Medicine Grand Rounds. I hope everybody's well today. Before we introduce our speaker, a couple of announcements or important comments. First of all, I'm very proud of our residents. Usually they do extremely well in the poster competition at the ACP chapter and the Kentucky meeting. And this year, 5 out of 6 residents actually won awards. So that's terrific. Then you can applaud. I'm sorry? There you go. So Amy Higgins won first place for the resident clinical vignette, and Nevin Murthy the third place. And then for the resident research, Chris Miltlury, and then Ninad Maniar actually got the second and third prize. So if you see them around in the hallways, just congratulate them. Jeff Kalin, Dr. Jeff Kalin is in the corner. He starts his year, is that correct? As the second year as president, 2 years as president of the Association of Professors of Dermatology. Do I have that correct? Excellent. Congratulations, Jeff. On this day, back in 1821 was the birth of Rudolf Virchow. You all remember the little nodule on your supraclavicular area. He was a German pathologist who originated the concept that disease actually starts in individual cells and tissues. And he published a publication called Cellular Pathology in 1858, and that founded the science of cellular pathology. Now, in the past week and this week, we've been listening about Nobel Prizes. And in 1863, on this day, Alfred Nobel was granted his first patent for the preparation of nitroglycerin, a preparation in a way that he did. Somebody else had discovered it, but he did it in a way that you could use it without killing yourself all the time. Now, a number of great people have won Nobel Prizes, but related to the talk today, I want to remind you that in 1923, Frederick Grant Banting and MacLeod and Frederick's student, Charles Bess, although he wasn't included, but was a co-discoverer of insulin, and for that they won in 1923 the Nobel Prize in Physiology and Medicine. And then a few years later, in 1929, someone who was born this week, Sir Arthur Harden, who was an English biochemist, won the Nobel Prize for his work in the fermentation of sugar and the enzymes that were involved in the degradation of sugars. So Nobel Prize has been on my mind, and I'm just going to leave you with this quote. Come gather around people wherever you roam, and admit that the waters around you have grown, and accept it that soon you'll be drenched to the bone. If your time to you is worth saving, then you better start swimming or you'll sink like a stone, for the times they are a-changing. Yes, Robert Allen Zimmerman, Bob Dylan, wins today, 2016, Nobel Prize for Literature, for having created new poetic expressions in the great American song tradition. And with that, I leave you with Dr. Steve Winters, who's going to introduce the speaker of today.
Thanks, Dad. I'm sorry you had said all that. I'm a music devotee, and I was about to say something also about Bob Dylan. It's quite an extraordinary person. Our speaker today is also quite extraordinary. Dr. Krishnasamy is an associate professor in our division. She joined the division in 2006 after she completed her fellowship here. She's very involved in our training program as the associate director of the fellowship program, and she runs our fellows clinic. She supervises our fellows in the clinic together with some of the other faculty. She works as the service chief at the University Hospital, where she's deeply involved in diabetes care, primarily something called the Diabetes Care Insulin Task Force, which establishes diabetes programs at ULH. She's busy at the Veterans Hospital with a 5/8 appointment, where she's on the board of directors of the Clinical Research Foundation. So she really helped initiate and get going a lot of I'll get it in a second. Clinical trials, industry-sponsored clinical trials at the VA. Among her interests are cystic fibrosis-related diabetes, diabetes in organ transplant patients, and the metabolic disorders in bariatric surgery patients. She finds time in her busy life to be involved in community activities, involved with underserved population, and she's certainly, in that regard, a role model for young doctors and for us older doctors as well. So with that, we'd like to introduce Dr. Krishnasamy to talk today about hypoglycemia.
Thank you, Dr. Winters and Dr. Owen. Thank you all for being here today. I know it's Research Louisville, and it's kind of a busy time of the year. I'm really honored to do this talk because, as Dr. Owen mentioned about the Nobel laureate 1920s, also the work that I'm going to present, or the data I'm going to present, is work of some really well-known pioneers in the field of glucose metabolism, especially Phil Cryer. Many of you all may have heard about him from Washington University, and some of the others in the field. So it's really a great honor to talk about their work. Let's see. Okay, so I start with this quote from Elliot Jocelyn, who is one of the greatest diabetologists, started the idea of diabetes education. And the patient who knows the most lives the longest, and we all could agree to that. And I always, many of you all who have heard my talks know I always dedicate the talk to somebody I feel like that helps the cause of the talk. And this time I'm dedicating it to our educators, nutritionists, nurses. Some of them are in our audience here today. Also the clinical pharmacists who help me a lot in the multidisciplinary clinics, family members of these patients, caretakers, researchers and clinicians, and also advocates such as ADA, JDRF, and all those who help these patients with diabetes, which is, as you all know, really terrible disease, and it's called the tsunami and of truth. So the objectives will be learn about glucose homeostasis in health and disease, beware of the clinical manifestations of hypoglycemia in diabetics and non-diabetics, list the causes of hypoglycemia in persons with diabetes, and learn about novel technology. And this focuses mainly on patients who are diabetic, not on the non-diabetics. And this relates to the most recent news that you all probably, I did mention briefly in the ACP talk last week, but mostly about the artificial pancreas or the bionic pancreas. So no conflicts of interest to disclose. So endocrinology is, I call it investigative endocrinology when I tell the fellows, because in a way we are really investigating this, and it is a modified job of Sherlock Holmes, whom I like to use as a model here. Actually, since I'm a woman doing this talk, I'm going to perhaps add Nancy Drew here, so who is, thank you. So anyway, we start, as always, with a case. And this was a case that me and the fellows saw over a weekend in July. July is always an exciting month in service, which my 10th year of July here. 89-year-old non-diabetic, African-American female, a resident of a long-term care facility, admitted to the hospital after she was found unresponsive by her nursing staff early morning hours. So naturally, among other things that were done, including vital signs, fasting blood sugar was done, a finger stick, and it was less than 20. And that was confirmed by a venous sample later in the ER, just to reiterate that it's important that we confirm every low sugar, if it's significant, later on with a venous sample. So resuscitation by EMS was done with IV D50. She didn't respond very well, so she required a few more amps of D50. And when she was admitted to the ICU, she continued to be on D10 infusion, which is when we were consulted, and my first year fellow at the time, Dr. George Vavlis, saw the patient. And this was, the rest of the information is heart failure, history of heart failure, hypertension, atrial fibrillation, reflux, deep venous thrombosis of right lower extremity history, so she is on anticoagulation. Upon review of systems, 100-pound weight loss for almost a year with non-bloody diarrhea over 3 months. So we were a little bit concerned about perhaps that she may have a tumor happening there. And also she complained of worsening edema, By the time we saw her in the ICU, she was awake, alert, and she was able to respond to questions. And on exam, she was tachycardic, and she had bilateral rals consistent with a heart failure and pedal edema. And her blood glucose measured, even in spite of resuscitation, was 30 milligrams, and this was a venous lab draw. Kidney function was normal. It's important to look at kidney, and we'll talk about that in a minute. C-peptide, 13 nanograms per ml. Insulin levels, 8.8. Proinsulin, cortisol, and her A1C, 4.6%. Ketone bodies, beta-hydroxybutyrate, which we always check to see if the patient's hypoglycemia is insulin dependent or not, and that was undetectable, which was suggestive that it was probably perhaps related to insulin or one of insulin derivatives. Antibodies, insulin antibodies were negative. So I wanted to put out this very nice, I know you can't see it very clearly, but this is a Cerner kind of a time plot of the endocrine worksheet snapshot. And Dr. Deuce here has really been very helpful with helping us develop this. And the insulin levels are right here, 9.8, when the blood sugar was 30, which by itself is a clue that it is an insulin-dependent hypoglycemia. And her C-peptide right here was pretty high there. And of course, the final answer here, which many of you all may have already suspected, we sent out levels, and this came weeks, probably days later, but she had positive sulfonylurea screen in a non-diabetic. I'll tell you in a little bit towards the end of the talk how it happened that a patient who was not a diabetic ended up with sulfonylurea, but this has again and again been an issue, and it's also a question in the boards, and one has to always suspect drug-related hypoglycemia when a patient presents who is not supposed to be on the medication. So I'll stop here at this and move on to the next part of the talk, which is talking about why is it so important to stand here and give this talk, because the healthcare cost of diabetes and treatment-related complications are extremely, extremely high, billions of dollars. I won't go into the details of it, but this is just some data from a study published about 2 years ago, showing the emergency room visits in patients with diabetes or on insulin with or without oral agents, and about 100,000 in about 4 years, national database. So it's a pretty expensive complication. So with that said, I will move on to the next part of the talk, which is glucose metabolism. This will take you all back to your biochemistry days, first year med school, so bear with me. If you all enjoyed this Krebs cycle and TCA, well and good. If you didn't, you just have to listen to it a few minutes, because this is very important for what we are going to learn and understand about hypoglycemia in healthy individuals and also those who are ill. So the source of glucose in the body is from threefold. Mostly it's the gut absorption right here, and then the second source is glycogenolysis, glycogen stores being broken down into glucose by glucose 6-phosphate. Most of that happens in the liver and the kidney right here. And also the third source is formation of glucose from lactate to pyruvate, and also from amino acids, alanine and glutamine. And glucose that's formed from these three sources is available in the bloodstream. So when someone fasts for about 8 hours, and I know we just came out of a major Jewish holiday of almost 18 to 24 hours of fast. And so someone is fasting, there's glucose available for up to 8 hours. And beyond that, the brain has to send signals to the liver and the kidney, mostly the liver, to start breaking the glycogen and also form glucose from lactate and pyruvate. The rest of the glucose, the fate of the glucose is mostly into acetyl coenzyme A, which then later on can be broken into ketone bodies, or it can be formed as fatty acids into triglycerides. Probably you're familiar with the tricarboxylate cycle, the TCA cycle as it is well known, where the pyruvate enters and there's formation of glutamine leading to glucose formation here and back. So, and that is about glucose metabolism and in healthy individuals. And this is about insulin, how insulin is secreted, because insulin is the major factor for glucose homeostasis in the body. And so insulin production here happens in the beta cells, and glucose enters the beta cell through the GLUT2 transport mechanism, and there it is converted to glucose 6-phosphate, and there's an increase of ATP. When ATP increases, that closes the potassium ATP-mediated potassium channels, and this channel is important in sulfonylurea use. And when potassium channel closes, that opens the gated calcium, the voltage-gated calcium channels. The calcium is released, and that causes exocytosis of insulin from the granules, and insulin is released into the bloodstream. And what are the hormones that control insulin release? Well, major hormone that controls, or three factors that control is, apart from the glucose, is cholecystokinin, GLP-1. I spent a few minutes last week talking about GLP-1, glucagon-like peptide 1, and also glucagon, which is produced in the alpha cells in the islet cells. And these are the three factors that stimulate insulin release. What impacts or prevents or insulin release is somatostatin, which is in the delta cells of the islet cells. So beta cells, insulin, alpha cells, glucagon, and delta cells, somatostatin. And also the other hormone called pancreatistatin also prevents insulin release. So that is kind of the insulin-glucose interaction. So what does insulin do? It primarily, insulin receptors are everywhere, primarily in the brain, in the hypothalamic area, and also several other areas. Insulin causes uptake of glucose into the muscle, especially during a post-meal phase, and also improves the uptake of glucose into the liver, and rest of the glucose is stored into the fat cells and improves the lipogenesis. So when patients are worried that, well, I'm on insulin, I'm gaining weight, and sometimes you know why. It's a white adipose tissue, and it decreases lipolysis and improves lipogenesis. And so it is very important, tightly controlled mechanism between all these different organs, vital organs, and that is very important as we move on towards the next phase of the talk. So glucose influx into the circulation is equivalent to glucose efflux from the circulation. So apart from the exogenous glucose delivery, the brain is your biggest utilizer of glucose. I don't know how many of you all had the bagel and the orange juice today up in the front, but it is pretty powerful. It's the main metabolic fuel is glucose. And when glucose is absent, it breaks down ketone bodies and starts using that for its fuel. So when in the absence of, when the glucose levels go down and the brain signals, what are the first steps that happen? Glycogenolysis and then gluconeogenesis, which we just spoke about. And also, most of it, majority happens in the liver, as I mentioned, but some of it does happen in the kidney also. So when we talk about the total endogenous glucose production. It's not just the liver alone. There's a little bit in the kidney also, and that's very important to remember in this as we move on. Just putting it all together, when blood sugars start going down in the state of fasting in a healthy individual, the first thing that happens is insulin goes down, and these are the values that this starts happening in a normal healthy person, about blood sugar of 80 to 85. And the next thing that happens is glucagon levels go up, glucagon from the alpha cells. So that's your first line of defense is decreased insulin, second line increased glucagon, and that is primary glucose counter-regulatory factor. And the third line of defense is epinephrine, which is a adrenomedullary axis. And that is your third line of defense. And that happens when the sugar drops 10 points below when the insulin is turned off. And the fourth line, which is not as important, but it is present, is cortisol and growth hormone. They also are part of this, but they're not very critical. But when you have a patient with panhypopit, sometimes they do present with hypoglycemia. That's one of the ways they present because of cortisol and growth hormone deficiency, especially when they are under stress. So putting it all together, and this is Phil Cryer's seminal work that he did for over 30 years, looking at mechanism of, he calls it glucose counter-regulation. He modeled the term for it. And it involves all vital organs, the brain, the central part is the brain, and the pancreas, and the liver, your kidney, muscle, adipose tissue, adrenal medulla, and several other factors here. So anytime the sugars drop, the symptoms include increased acetylcholinergic symptoms, which is cholinergic symptoms such as sweating and hunger, adrenergic symptoms, palpitations, tremor, and some tachycardia and other symptoms. And then ingestion of carbohydrates. If there is access to carbohydrate, you ingest it. And so there's increased glucose production. When the glucose levels go up, the opposite happens where there's less glycogenolysis and it's taken up by the fatty tissue and muscle. So that is pretty much the work that Phil Cryer, and it's interesting how it was done. He used healthy humans and patients who have been, had undergone bilateral adrenalectomy, and he blocked off glucagon and growth hormone production by using IV somatostatin, and later reintroduced each one of these hormones and was able to very nicely, very elegant work, look at what is the first defense, what is the second defense, what is third defense. And I think that has helped us all understand this glucose metabolism much, much better. And if you have some downtime, I would like for you to read one of the publications by his mentee, who is Dr. Sam Degogojak, who's a chief of at UT Memphis, University of Tennessee, Memphis, yes. And that kind of is sort of his salutation to his guru, talking about his whole life and what the studies and everything. And it was published in Diabetes Care a few months ago, December 2015, I believe. So let's move on to the next part of the talk. And before I go, I just wanted to remind you all that the brain fuel glucose, glucose crosses the blood-brain barrier. And when the interstitial glucose is a certain amount, the brain needs just 25% of that. That is for adults. And in the fasting state, that's about 80 to 110 in most people, unless you're pre-diabetic. And in children or infants, it's a little different. The infant brain is proportionately much bigger than its body, and the infant uses a lot more. So it's 3 times more fuel that the infant needs. So that's why you have to feed the infant every 2 to 3 hours. Just a quick word about the sensor, because this is some really elegant work by Bob Sherwin from Yale University, along with several other pioneers in this field. And this kind of takes us back to evolution of where organs were before when things started. And what I just wanted to mention that actually, it's this one. The ancestral home of the islets was learned from the Drosophila, which is the fruit fly, where the islets were actually in the neural crest. So, and that is why the islets and the brain are the two important areas where glucose regulation happens. We already spoke about where the glycemic threshold, where all these defense hormones are released, so I won't repeat that. Since we are into fasting, and the next thing I wanted to discuss is gender-based differences in fasting state, which was very nice studies done in the 1970s by Merriamy and Tyson. Tyson is from NIH, and they looked at healthy men and women, about two groups of them, who were not diabetics and who were fasted for 72 hours, which is the test that we use for looking at patients who have hypoglycemia to make a diagnosis. So, to talk about that, since in 5 days, many of my friends and people I know from northern province of India will be celebrating this big festival where the women of the household fast for their loved ones from sunrise to sunset. I mean, till the moon appears, actually. You can't eat or drink. So early morning, they get to eat some food, and that's it. All day you fast, and then you break your fast after you see the moon. So it's kind of interesting that the women are the only ones who do this fast and not the men. And for that, this is interesting to know that the women tend to, in this study that I talked about, when you fasted for 72 hours, the healthy women tend to drop much lower into blood sugars as low as 40, but the men dropped to 60 to 50. But the women who dropped even as low as 30 and 40 were asymptomatic. They didn't have any symptoms, and that's important to know. And we all should agree the fairer sex is a little bit more complicated. So, so that's about gender differences while fasting. And just this year was the first time, International Diabetes Federation did put out guidelines about fasting during the holy month of Ramadan. It's available online in the International Diabetes Federation. Very nice guidelines for those. Since Louisville, university is more global and we take care of a lot of different patients, it's important to be aware of helping your patients who are diabetic who fast during the month. So that brings us to the definition of hypoglycemia. In a patient who is not a diabetic, there's no history of diabetes, to call someone that they're hypoglycemic and to continue investigation and go through extensive 72-hour fast, it is important to understand that these patients, first of all, need to kind of fulfill what we call the Whipple's triad. Serum glucose less than 50, symptoms of neuroglycopenia that we talked about, the adrenergic, cholinergic symptoms. And in fact, many patients say they feel brain fog. That's the most important thing. I'm stunned, I can't think. So relief of symptoms by administration of food or glucose. So that is kind of the hallmark of hypoglycemia, which needs further investigation. That was described in 1930s when Whipple was looking at insulinomas. So let's see. So hypoglycemia in non-diabetics, which is the next section of my talk, traditionally the classification was fasting state and postprandial or reactive state. However, the newer classification, we look at patients who are non-diabetic and call them, are they healthy non-diabetics who are hypoglycemic? Are they sick in the hospital? I'm sure there's some intensivists here. Critical care or hospitalized patients who's hypoglycemic, such as the patient we were called on. or several other patients that we usually get called in the service. And very nice guidelines by Cryo's group in Endocrine Society in 2009 about the workup of these patients. So critically ill patients in the hospital, the most common reasons would be what we already looked at in terms of, in the healthy state, the important organs that play a big part, the liver, the kidney, and also heart failure, and sepsis, inanition or malnutrition, which we got consulted in July for one of those patients who was admitted with necrotizing fasciitis of her right lower extremity, underwent amputation, and was quite hypoglycemic, and we were consulted, and we were almost considering tube feeds because she was so malnourished, but then she quickly started eating every day, and her sugars went up spontaneously. Also, the other reasons would be drugs, alcohol, and insulin secretagogues, such as the one the patient we just talked about. And also hormonal deficiencies, as you can recall, those hormones which are in the defense of hypoglycemia, cortisol, epinephrine, glucagon, and the glucagon epinephrine is mostly insulin deficient diabetics. So, and the other group of patients whom we can get called is from the hem-onc unit, and that is patients who have tumors, but they're not insulin-producing tumors. They are non-islet cell tumors, and I wanted to list those. Probably in just a minute, I'll talk about what those tumors are. So I mentioned liver, kidney, inanition, sepsis. Just spend a couple of minutes about liver and kidney because they're quite important. And before we go that way, I want to tell you about another patient that we got called. Always it's a Sunday afternoon when it's hypoglycemia. About a few years ago, and the fellow called me in panic. The blood sugar is 10. The patient is admitted for the 4th time in the past few weeks. And so since it was first or second week of July, I actually drove in, although it was late Sunday afternoon. And she was happily sitting and chatting. And we looked at her case history. She has a history of vasculitis and I think inflammatory bowel disease. So I told her, can you please show me your hands? And I don't know how good the lighting is, but she had Raynaud's. So you try doing a finger stick on a patient who has Raynaud's phenomena, you're going to always get a low sugar. So always look at the patient before you look at the number. So, and that's something very important. Raynaud's pressors in the ICU, many patients who are on pressors, hypotensive, blood sugars, just like checking oxygen, it's going to be the same problem. Hypotensive and very anemic patients also many times we do encounter that problem. Just about 2 or 3 days ago, the FDA did release some guidance for a document looking at finger stick blood glucose monitors because there's so many out there. There's a lot of generic name brands, use several reagents, and one wonders the differences or what is accurate, what is not. Patients bring in and say, my sugar was this a few minutes ago, and then your nurse just checked it's different. What do we do? So it's very important to understand this before we proceed further. So the liver and glucose, the sick liver is not a good thing for glucose because you at least need 20% reserve in the liver for gluconeogenesis and glycogenolysis. So it's very vital for glucose production. And like I mentioned, 20% reserve at least. And common reasons that we get consulted in Jewish with the transplant program is the steatohepatitis, alcoholics, and different patients, and definitely drugs. I know some of you all were at the happy hour yesterday, and I'm happy you made it back here. For the talk, but alcohol does have a significant impact on hypoglycemia. Acute intoxication can cause a decrease in gluconeogenesis, so that's why when you drink, you also have to eat. And it delays glucagon release and catecholamine release, so there's a blunted response to catecholamine release, and it inhibits growth hormone and cortisol. And it can occur as late as 6 to 36 hours post-ingestion, especially in known alcoholics who are malnourished because they don't have much substrate to produce glucose. And also alcohol levels and glucose levels correlate poorly, so it's not very helpful. And the kidney is another area that is very important. It's multifactorial when there's hypoglycemia with kidney disease. For one thing, there's decreased drug clearance, so you have a patient who's getting insulin, especially the older insulin like regular. It's not cleared very well, so there's a higher risk of hypoglycemia. Dialysis patients have amino acid deficiency. Many of them have, they are malnourished, they are uremic and cachectic, and also there is, because of the dietary issues also, there is some higher risk of hypoglycemia. So sick kidney is not good for the glucose. I did mention a little bit about that was about sick patients in the hospital. And this is mostly healthy patients that we get called in the clinic most of the time, or we get consulted. And that is a common reason would be non-insulinoma pancreatogenic hypoglycemia, so-called NIFS or nesidioblastosis. I won't dwell on it too much, but the one that is a little interesting is the post-gastric bypass hypoglycemia, which commonly everybody gets to see, especially if you didn't know about the history that they underwent gastric bypass, or in the case that we had a few years ago at the VA, where the patient underwent a Billroth 2, which probably the students now probably haven't heard of at all, where the patient has hypoglycemia every night. He eats ice cream, then goes to bed. Within 2 hours, he has to get up and change his clothes because he's drenched in sweat. Well, it took us, we finally saw him in the clinic and went through things, and he didn't think it was important to mention that he did have the surgery in the 1970s. Turns out he had dumping syndrome from having the Billroth 2, which is almost similar to the Roux-en-Y. So also the other interesting one, which I have only heard of it and just saw my first one a few weeks ago at the VA clinics, is Hirata syndrome, which is antibodies to insulin. This patient was admitted several times to several different hospitals with hypoglycemia. He's in his late 80s, and the autoimmune, the antibody levels were almost 2,000 or 3,000, quite high. With steroids on board, he's doing extremely well, and through home health, we've been tapering those steroids. So, so 72-hour fast is the way we diagnose non-diabetic hypoglycemia patients. And the criteria is failure to suppress insulin to less than 6, and C-peptide over 2. And when your fasting blood sugar is less than 50, if the insulin is over 6 or the C-peptide is higher, that gives a diagnosis of insulin-dependent hypoglycemia. And the other criteria is, skip this part, is at the end of the 72-hour fast, we administer glucagon, and if the glucagon increases blood sugars by at least 25 points, and that is kind of classic for insulin-dependent hypoglycemia, whereas if it's non-insulin dependent, usually glucagon does not cause higher blood sugars. So I did tell you about non-islet cell or non-insulinoma tumors that can cause hypoglycemia. 50% of those tumors are mesenchymal fibrosarcoma. We had one a few years ago, which was pleura-based fibrosarcoma, and several others, liposarcoma, mesothelioma, and sometimes the presentation is with hypoglycemia. And the other group of patients, hepatocellular cancer, 20 to 25% of non-beta cell tumor hypoglycemia is related to those. They do not produce insulin, they produce IGF-2. And also adrenocortical cancer, carcinoids, big neuroendocrine tumors, pancreatic adenocarcinomas, and certain hematologic malignancies, leukemia and lymphomas. I'm going to probably skip this part of, and move to the patient that we had a few months ago, who was referred to us for a history of gastric bypass, but had, at the end of the day, is a nurse, and at the end of the day would feel extreme fatigue and brain fogged. So we decided, our educators and nutritionists here, Beth and Paula, we placed what we call as the continuous glucose monitoring system, and monitored for about 3 to 4 days, and were able to get up at least 1,026 readings per day, using the sensor, which is placed in the, and that measures the interstitial glucose, and is a signal called ISIG, and then it produces calibration factor and continuously spits out blood sugar values. And as you can see, patient goes home, eats something, and the time he says he has fatigue or it drops really low is right after he eats a meal. And our nutritionist, Beth Ackerman, went over what he was eating, and then we found out that the food he was eating was not exactly a mixed meal and mostly high carb. And we were able to kind of go in and looked at it, because when he was checking his finger stick, we never got the information correctly. This is another patient of Dr. Abel's clinic who was referred to us. She had undergone Nissen's fundoplication and later had a complication, underwent gastroplasty. And so it's almost like having a elaborate gastric bypass. And she had severe hypoglycemia throughout the day at work, almost to the point her coworkers would know when she was hypoglycemic. So, but we didn't know what the pattern was and what was triggering the hypoglycemia. She would dip as low as 30s and 40s, and she did a food diary along with this sensor, and we were able to adjust her dietary factors, although it's tricky in this patient given the anatomy of her gastrocolic system and the complicated anatomy and the dumping, but we are working towards trying to find a happy medium here. And this is her average blood glucose over the months, over the few days she wore, as you can see how low she goes. The one other area where we see a lot of reactive hypoglycemia early on, before the patient becomes diabetic, is CF, cystic fibrosis. And there's not a whole lot of research done in this area. There's probably about 5 or 6 studies, and we don't know the mechanism. Many of these patients are still not diagnosed as diabetic. They haven't had a positive glucose tolerance test. However, they have what we call as reactive hypoglycemia. They eat, and they can drop their sugar as low as 30s and 20s and be very symptomatic. And as you can, these patients also have exocrine pancreatic deficiency. So we do not know if that has something to do with this, but certainly that's an area which is open to research. I'm going to skip the part about given the short time we have, I'm going to probably skip this part and go to the next section, which is type 1 diabetes and technology. So I don't know if anybody in the audience recognizes this person here. Mary Tyler Moore, yes. Sotomayor, okay. Holly. Anybody? Ryan Reed, okay. Ryan Reed, NASCAR driver, and there's a very interesting story about him. This one probably students or residents should know. Nick Jonas, the singer. So what do you think they all have in common? Type 1 diabetes, yes. So Mary Tyler Moore was JDRF president at one point, did a lot of work. And the final person is actually little Coco. My pediatric colleagues would know Coco very well. Lily and Disney together developed this character so that young kids with type 1 diabetes would understand. And Coco, as you can see, wears a medi-colored bracelet, which we remind all our diabetics to wear. And there's several little children's books about this character. Coco. So insulin has one of the biggest problems using insulin, which, as Dr. Roman mentioned earlier, the Nobel laureates won it, but it also has a dark side to it, and that is hypoglycemia. And as Phil Cryer calls it, it's the Achilles to controlling or getting euglycemia is the hypoglycemia in this. So Elliot Jocelyn, again, insulin is a remedy primarily for the wise and not for the foolish, whether they may be patients or doctors. Everyone knows it requires brains to live long with diabetes, but to use insulin successfully requires just more than brains. So this was a case which was published a few years ago in Endocrine Practice. This was the only case where we have some evidence what happened when the patient had what we think is the worst nightmare, where a parent can go in a room and find their child with type 1 diabetes, and that is dead in bed. And that is severe hypoglycemia. So this young kid, or actually young adult, had been type 1 diabetic since his, I think, 3 or 4 years old, and had multiple episodes of seizures, hypoglycemia, and finally 2 or 3 days before, he had been on pump therapy. 2 or 3 days before this happened, a sensor was placed, and this is what you see with the sensor. He drops pretty low, so obviously, as the title says, he was found dead the next morning, and there was no evidence of seizure activity, so the sensor was taken out at postmortem and downloaded, and this is the kind of the terminal event that happened. Blood sugar dropped, but his mechanisms of counter-regulation, which we went over earlier, which is epinephrine and glucagon, did not really take it up too much, as you could see. He dropped all the way, but couldn't really work. And of course, he eventually did go down into a coma, and that's kind of sad. And that is kind of the flip side to tight control for diabetes, is not being able to achieve it without causing significant hypoglycemia. So what happens in advanced type 2 diabetes and type 1 diabetes always is what we call as beta cell failure. So these patients are insulin dependent, so there's no intra-islet insulin. So the islets do not detect that there's insulin present. So even though there's therapeutic hypoglycemia or therapeutic hyperinsulinemia from the insulin that's given by us for these patients, the glucagon release does not happen when there's hypoglycemia because the intra-islet levels do not go up. And that whole mechanism, and because of that, there's kind of a delay in epinephrine and adrenaline and cholinergic effects. So that causes, it's called hypoglycemia begets hypoglycemia. So the brain kind of resets its glucostat where it can sense hypoglycemia. So these patients can go lower and lower and not feel the symptoms. And many times, first time they feel it, they're actually seizing. And that is kind of a scary part of advanced type 2 diabetes and many type 1 diabetes. It's called hypoglycemia-associated autonomic failure. A lot of times if you see our notes and we write HAAF, that's what it means. It's also otherwise called as Cryer syndrome, after Phil Cryer, who defined it. And many times the concern in these patients is that they're like the patient that I showed in the case report, is that they go into, they have QT prolongation, many times heart block, and many times ventricular fibrillation can happen. And so it's very important to kind of treat hypoglycemia in these patients, or kind of avoid it, and train these patients, behavioral modification, go through adjustment of insulin, dietary patterns, and that is where education is very important. And also the new technology that we have available to us, just like the sensor I showed you. And more recently, the FDA is looking into looking at continuous glucose monitor in place of finger stick blood glucose testing, which, so maybe a few years from now in the hospital, instead of the nurse having to go in and check blood sugar every time, we may be having patients wear their sensor, and we can sit somewhere and just kind of look at the numbers and go in when they're going low. So that is kind of a nice thought. And I'll, the one that I wanted to actually mention a few words about is the news from 2 weeks ago, which is the closed-loop hybrid sensor-augmented pump therapy, which is a pump and also a sensor. And we do have already something available with this. However, that sensor, all it does is when the patient's blood sugar drops to a certain threshold, it suspends the pump. It's called threshold pump suspend technology. However, this new pump, which should be available hopefully next year, and the cost, I'm not even sure about it. Let's not even go there. But this study was just published last week, is not only does it threshold suspend, but between meal times, it does look at the blood sugars and regulate. The sensor kind of provides recommendation about adjusting insulin during interprandial times, which is almost like a pancreas in a way. And that is pretty much about the bionic pancreas. So in summary, we talked about definition and healthcare burden of hypoglycemia, case-based homeostasis. We talked a little bit about how the neuro, gut, islet, liver mechanism works. Hypoglycemia in ill and well patients. Beware of drugs, the listed and unlisted ones, and real and unreal causes. Make sure you look at their fingers. And fasting hypoglycemia is more ominous. It means tumor many times. And we talked a little bit about the cryo syndrome and advances in the diabetes technology. So many times, a combination of logical reasoning disguised, just like Sir Arthur Conan Doyle mentioned years ago, and also looking at lab data, making sure there's no sampling error, the sample wasn't sitting for a long time, what medium, what transport mechanism, all those are very important. So this patient that we had, what we found later, why would a non-diabetic end up getting sulfonylurea? Turns out it's an older long-term facility where the Pyxis had the labeling done. I don't have the picture very nicely, but so the label was on the bottom, so whoever was dispensing the drug picked the one from the top, so it ended up being the sulfonylurea. And her levels were actually pretty high. So that was kind of the story on that patient, which was interesting but very expensive. So what are we doing here in terms of hypoglycemia, as Dr. Winters mentioned? We are in the multidisciplinary group. Some of them are here. It's a very good interdisciplinary group with hospitalists, intensivists, pharmacists, medical informatics, nursing, and we are the DKA protocol, unifying protocols, whether we go to Jewish or Norton or VA, hopefully we'll have the same protocols. And also revising and unifying hypoglycemia guidelines. I'm working with the Kentucky One Inpatient Diabetes Task Force there. We actually met 2 weeks ago in Lexington. Our inpatient educator from there, Shanna Nicholson, is here also in the audience. And in the outpatient clinics, we do have this accreditation by ADA for diabetes self-management education program, thanks to our very able educators. One of them is not here today, but the other two are here, Paula and Beth. Also we are looking into, there is glucagon in the crash cart now at office there, so, and hypoglycemia policies and other things. So I wanted to kind of stop with this young lady who was one of the first few to get insulin treatment. She was barely 45 pounds hypoglycemic, 45-pound type 1 diabetic in the 1920s. The other picture looks a little kind of disturbing, so I didn't show it to you. Her pre-treatment picture, this is post-treatment, and this makes it all the more gratifying to do this. And also just a note about my title, which is From Unreal to Real, From Darkness to Light. It's from one of the very ancient scriptures in the Hindu Vedas. Talks about, actually the darkness to light talks about actually knowledge, from no knowledge to knowledge. So hopefully, also it says death to immortality, but hopefully I was able to shed some light into what our understanding of hypoglycemia is today. So thank you all for your attention.
Thank you. So I had a couple of questions. One is, in the setting of a tumor, at what stage do you begin an elaborate diagnostic workup? Because I assume that tumors are the least likely to be causing hypoglycemia.
That's right.
And the second question I have for you is this concept of poor regulation or counter-regulation that we suffer, that many patients just simply can't reactivate those counter factors. Is there a scientific, this is a sensor problem?
That's right.
Or a production problem of regulatory factors? What's known about that? So the first is the tumors.
Yes.
When do we
Yeah.
evaluate that?
Yeah, so-
And the second one, what do we know about these sensors?
So the tumors, I should go back to the Whipple's triad. So if they don't have the Whipple's triad, which is very severe, pretty low sugar, neuroglycopenic symptoms, and treatment of the treatment of the low sugar reverses the neuroglycopenic symptoms. And no evidence of drugs or other instigating factors like liver, kidney issues or anything that could be causing it. So we've had at least 2 or 3 patients, and usually these tumors, the mesenchymal tumors, are actually very hard to find, as you may be aware. Some of them are pleura-based, and PET scans, and many times very elaborate, extensive workup has to be done. Many of these patients, unlike the insulinoma patients, they are losing weight. They do look like they have a tumor. They do have, they look pretty cachectic and, have a lot of other markers of having tumor. So that's about the tumor. And the IGF-2 is easily available assay, and we have checked it in the past. The second question about the counter-regulatory, the HAF, I call it, HAAF, is it's a complex phenomena. Most of it is as the patients, and there have been very elegant clamp studies done at looking at what point does someone start sensing if you're healthy, at what point does someone start sensing low sugar if you are diabetic, and those are very significantly different. And I have to go back to, I missed some of the slides because of time, but the DCCT showed, the DCCT is very nicely shows the tight control and the poorly, kind of usual control. There's 2 groups in the diabetes controls and complications trial, which was kind of one of the trials which we refer to always when we talk about control and complications. So the tightly controlled patients definitely had a lot more hypoglycemic areas, and also they had HAF, because the tighter the control got, the brain kind of the sensing mechanism went down, and some of these patients did undergo clamp studies with insulin infusion and dextrose, and that was shown. And many times it's more so post-exercise and during sleep, because already your senses are not so alert. So sleep and exercise and illness is when it happens. And usually if you have hypoglycemia, within 12 hours, you're more prone to another episode of hypoglycemia, and that's why in inpatients, we need to constantly, it's a dynamic process, changing the insulin dose and everything.
Questions, comments? Yes, sir.
I have a question about the new artificial pancreas system just approved. I know when it had first come out and approved that there were concerns about the safety of it, with it being without any kind of security, and the initial response I heard was that, well, you have to have physical proximity to it, but with everything in your house having Wi-Fi and Bluetooth in your refrigerator, it doesn't seem like it's too far-fetched that in the near future, if not now, that actually could be an issue for terrorism.
Yeah, definitely there's concerns, and I think it's being addressed. But I can tell you, even before this is not even in the market yet, but 2 years ago, there was a very nice study done in Boston by Steve Russell, I think, looking at bihormonal, which is glucagon in one pump and insulin in another pump. And it was done in the Bacon Hill area. It's called the Bacon Hill study, and also in a summer camp with adolescents. So interestingly, they were also able to download the data into at that time it was iPhone 4. So It's a cloud data, and actually parents actually like the fact that they have a young child in school and they're able to look at the real-time blood sugars. So while we are worried about the hacking and those parts, there's also some good parts to it about the technology, about downloading, and patients now download their data and then they share their password, and I'm able to, me and our educators and nurses are able to look at it, and we are able to, make changes and adjustments. So I think, but that part of, where it's interference with other electronic devices, I'm not 100%
I
sure.
don't think that those things have to be mutually exclusive, that it wouldn't be able to securely have it automatically upload into Cerner or into Allscripts, or at least be accessible, and also have a amount of security so that others can't.
That's a good point, but I don't know the answer to that. Yeah, but it's something.
Sathya, thank you so much. This is wonderful. Thank you all.